Okay.
Yeah, so can you see it now?
Yeah.
Okay. So I'm going to talk about why do I do most for the acral melanoma. And I'm from Taiwan. I'm a dermatology surgeon in Merkel Memorial Hospital. Okay. Okay, I don't have any conflict of interest to declare. So I'm going to follow these outlines. The first one is how do we interpret acromelanoma cells, whether by frozen section, that what we do for the BCC and SCC, or by paraffin embedded section. And the second part is that why do I do most for acromelanoma? The main issue is because there is a significant part of subclinical spread of acromelanoma. So I'm going to talk about how do I define the tumor bark and how do I define the margin, including the melanoma in situ from T1A to T4B melanoma and subungual melanoma and recurrent melanoma. Okay, so that is publishing last year, which showed that in Taiwan, there are 60% of melanoma still located in the feet region. And if we focus on the soul, about 20% is in subungual. And all other part will be distributed around the front of foot, mid-foot arch, and the heel. So the main problem is that the acral lentiginous melanoma often has a significant subclinical lentiginous compartment that may extend beyond the standard margins using wide local excision, and it requires exhaustive histology assessment to ensure the local control. So it is a current guideline for the standard excision for the melanoma, but there is not a separate guideline for acrolentigenous melanoma. And because we often follow the United States guidelines, so even for the melanoma thickness about the 4 millimeters, we only use 2 centimeters. But if you look at the UK or France guideline for thickness about 4 millimeters, we use maybe about 2 centimeters margin. Okay, so like what David said, that currently there's some prospective studies. They use Mohs micrographic surgery for melanoma in situ or for melanoma. But this melanoma in Caucasian, they often located on trunk or face, so they can use a MART1 immunostain under the frozen section. But for acromelanoma, it is not so suitable. I'm going to talk about why the MART1 with frozen section is not so suitable for acromelanoma Mohs surgery. So the first part, I'm going to talk about how do we interpret the acromelanoma cells, whether by frozen or the...
Yes, good afternoon again. So I agree with you, David. Usually for cutaneous angiosarcoma, because the clinical suspicion can be a bit slow. So by the time we see them, it can involve a very big area already. So in some cases, like the entire scalp or like half of the face in elderly people. So those cases where you do see a lot of satellite clinical lesions may not lend themselves to being treated using Mohs surgery. So we do have to choose the cases wherein we treat angiosarcoma patients using Mohs micrographic surgery. So as we know, Mohs surgery is already well established for the most common skin tumors, such as basal cell carcinoma and squamous cell carcinoma. So as we know, the goal is 100% tissue microscopic examination and removal until clear margins. So the surgery and histopathology examination is performed by the Mohs surgeon. However, what is the role of Mohs micrographic surgery for rare cutaneous tumors? So in places where there is more Caucasian skin, obviously they will see more of these rare cutaneous tumors. So in this paper published in the JEADV, so they saw that although you get a lot of basal cell carcinoma, squamous cell carcinoma, these rare tumors, which include DFSP, atypical fibroxanthoma, Merkel cell, MAC, sebaceous carcinoma, extramammary Paget's, they only compose 3% of the patients that are treated using Mohs micrographic surgery. And they do emphasize the use of multidisciplinary teams to be able to treat these patients. And in a series done in Spain, again, mostly Caucasian patients, they did show that Mohs surgery was used for a lot of these rare tumors. However, their median follow-up time was quite short. It's only about 9 months, so 0.9 years, which I think, as we know, in these rare tumors, the recurrence rate can be quite high. So we need a longer interval for follow-up. So um, at the Makati Medical Center and Medical City Ortigas here in the Philippines, we do have a multidisciplinary team approach to treating these rare skin tumors. So which will include a Mohs surgeon who is adept at dermatologic oncology, medical oncology, surgical oncology, radiation oncology, and of course, nuclear medicine. Okay, I got it. Okay, thank you.
Thank you.
Okay, thank you, Chrissy.
Thank you.
Bye-bye.
Bye.
Bye.